kind introduction. I would like to thank the organizing committee for giving us an opportunity to share with you very exciting technology. So it's very interesting. Is it technology or technocrinology, and that's where we are looking at. So I'm going to tell you, can the algorithm drive insulin delivery in India? So the biggest challenge is CGM, because last decade belonged to CGM. Everybody was like, if you go to UK, if you go to other countries, if you have type 1 diabetes, they used to give you CGM and all. And I said this decade belongs to automation of insulin. But if you look at the CGM data, the CGM penetration is close to 70% in developed countries. And if you look at the outcomes, basically they are not very promising. So why are they not promising? So this is an interesting case. If you look at a lot of you getting this kind of CGM results in your clinic. So if you look at this CGM graph or AGP graph, the ambulatory, what do you think we should do? Should we increase the insulin delivery? Should we give more insulin? Because if you look, you can't just treat the mean. Most of the time, because unfortunately we treat the mean and we forget there is confidence intervals of 25 to 75% and 5% to 95%. So if you give more insulin in the night, then for some nights he may go into hypo as well. So that is the kind of problem with CGM. That is the biggest problem with CGM that we can. So it is not about whether we can do better work or not. Unfortunately, it is about the data that we get. The another problem with diabetes is that there are so many variables. This is one of the list of variables where they look at what are the different actions they need to take every day. So when they get up, as ma'am has already mentioned, dawn phenomena, then getting up, calculating the carbs in the breakfast, looking at the BG, looking at whether they are going to do any exercise or not. So many different factors they need to consider to calculate the amount of insulin that they are going to take. So that is a big problem. So to solve these two problems, that is where the one of the solutions of automated insulin delivery is Medtronic's Minimed 780G system, and this system comes with a pump that is connected to your mobile phone via Bluetooth. It uses the Guardian Force sensor that is calibration free, so you don't need to do calibration twice a day. And in the future we'll get extended wear, so this is currently not available in India. In India we have infusion sets, we have to change it every third day. Now let's look at the challenge with basal insulin initiation and titration. So if you are sitting in your OPD and patient comes to you with last 3 days of glucose diary or last 7 days, and you want to change the basal insulin rate, what is the problem with that? So I call that 3D problem, because you are looking at the past data and in your clinic you are sitting there, you are making changes in the present, and with all your good heart you hope that that will help him in the future. But there is one problem that is occurring here, is that the time dimension is changing, and that is one of the difficult problems to solve due to lack of right data. Now imagine how does the automation handle this, because it is getting data every 5 minutes. So if you look at this this graph here, on the y-axis we have sensor glucose value, and on the x-axis the pink bars you can see, these are the basal insulin that is delivered every 5 minutes. Now if I give you the glucose data every 5 minutes and ask you to titrate the basal insulin, you all can do it, but then you have life to live and you have so many patients to look after. So that is where the automation comes into the picture, and what it does is that it changes the basal insulin every 5 minutes. Now you will say, okay, if it is doing everything, then what is my job? So if we are using Google Maps, we tell the destination, and the best way to reach there and the optimal time depending on the traffic or time is decided by the Google Map. Similarly here, as a doctor, you can set the 3 basal targets, that is 100, 110, 120. And then how much insulin to give and when to give is decided by the algorithm. Now you will say, okay, if somebody is going for exercise, then what is the big deal? How should I do? So that is where you have a temporary target called 150 milligram per deciliter. So if somebody is going for exercise which is not his day-to-day like unannounced exercise or sudden exercise, then that is where you can use this temporary target. Now you must be thinking, okay, we can do that, but what if sugar suddenly rises? Should I continue to increase basal rate? No. That's not how our body physiology works. And that's why ma'am has shown a slide where how does the when the sugar suddenly rises, we have to use the correction boluses. So how does the algorithm look at it? So algorithm has a threshold of 120 milligram per deciliter. So let's say sugar is rising. When the sugar is rising, first it tries to increase the basal rate. So you can see the pink bars here. When the sugar is rising, it is trying to increase the basal rate. But when the sugar goes above 120 and when it reaches max basal rate, now this max basal rate is decided by the algorithm every day at 12 o'clock in the midnight based on the last 3 to 6 days of insulin delivery data. So this changes every day. So once it reaches the max basal rate and still the sugar is more than 120, then it doesn't increase the basal rate. It starts giving auto correction boluses. Now imagine how we give correction bolus when we see that sugar is more than 300 or 400, when you get a call in the middle of the night. And the another problem with the way we give correction bolus is that we give entire correction bolus in one go. Then you can't go back to the bed, because then you must be thinking, did I give more insulin, did I give less insulin? So that is where this algorithm is different, in that it starts using correction boluses early when the sugar is already above 120, and it doesn't give entire correction bolus in one go. It gives in small increments, so the risk of hypoglycemia goes down significantly. And that's how it tries to bring the sugar or maintain it around the. Now, what is the problem with bolus? So you must be knowing this formula. So this is called bolus calculator, and this is available on the apps as well. So if you go to any Google Play Store, just download bolus calculator. This is available. Now if you look at this bolus calculator, there are three things that it considers. The first thing, it considers food bolus. Second thing, it considers the correction bolus, and third is the insulin on board. Now for example, if I am eating aloo paratha, 2 aloo parathas, it contains 65 grams of carbs, and if my carb ratio is 10, then I need 6.5 units of insulin for that. If my pre-meal sugar is 200, then I need to correct it to pre-meal BG target, which is decided by you, maybe 100 or 120. Then I need some correction based on my correction factor. I need 2 units. And then if whatever insulin is remaining from previous boluses, I need to subtract to get the right amount of bolus for that particular meal at that particular point in time. So 2-3 things that are changing here. Now what is the problem with this calculator? I will come back to it. The first problem is correction boluses, because 1 out of 3 times the high glucose episodes are not followed by the correction bolus. Now this is a Europe data, survey based data. I assume that this may be closely what is happening in our place as well. And then 1 out of 2 times correction boluses are wrongly calculated. Why? Because we are using correction factor, which is based on the empirical data, which is not like a full flow. Otherwise you have to admit the patient, give him 1 unit, check his sugar, and then find the right amount of correction factor for him, which is tedious. Now look at how does the algorithm use correction bolus. So algorithm uses the same formula, current glucose minus target glucose divided by ISF, but it doesn't give the sugar, it doesn't give the insulin, sorry. It looks at, if I give this much correction bolus, will this cause sugar less than 80 in next 2 hours? So it is using that prediction algorithm, it is trying to look into the future and understand that will this cause sugar less than 80 in next 2 hours. Now imagine if you have that kind of eyes, or in Mahabharata we have Sanjay. So imagine you can have some kind of this, a prediction, then you can also do that. So what does the algorithm does that if it thinks that it will cause sugar less than 80 in next 2 hours, it starts reducing it by 25% till the safe correction bolus is happening. Now you must be thinking, how much time does it take? It does it instantaneously, because it's a kind of computerized algorithm, so it does it very fast, and it tries to give only correction bolus which is safe to give. So that will give you, that will help you, or that will enable you to give more insulin to the patient. I am sorry for using wrong word here, please excuse me for that. I say it's carb gambling and not carb counting, because if you ask to estimate carb of a food to 3 different people, they all come up with different numbers, and we don't know who is right, who is wrong. So there are 3 possibilities. Either somebody has overestimated the carb, somebody has underestimated the carb, or somebody has just rightly calculated the carb. But if you look at the global data, it's 76% feel that carb counting is burdensome activity, and 2/3 underestimate the carb. Try when you are going for a dinner, try to estimate the carbs. And I am pretty sure you all will underestimate, and you will eat less as well. So try that. So what happens with this? Again here, it just uses the formula number of carbs divided by carb ratio, but it doesn't give that bolus. It doesn't give that bolus. It tries to see that will this cause sugar less than 70 in next 4 hours. Again, it is using predictive technology and seeing that if this bolus amount will cause sugar less than 70 in next 4 hours, it will reduce it by 25%, and this will go on till the safe meal bolus is found out. Now you will say, what is a big deal about this? Now this will enable you to give more insulin. What DCCD taught us is that more insulin, more injections, better outcomes. So that is, but the biggest problem was hypoglycemia. So if I am taking care of that, you can give more insulin, and more insulin will lead to better outcomes. Now there is one more thing, and I was discussing with Dr. Riaz, and he said how long it will take to reach fully closed loop, and I said it's very close. So one of the things is that meal detection technology. So based on the slope of sensor glucose rise and last 3 sensor glucose readings, it detects that the person has taken a meal and the sugar rises because of meal. As soon as it detects that, and if somebody has not taken an insulin, then it starts giving small correction boluses. So for example, if child is going to school and he forgot to bolus, so here then the algorithm will detect that and it will start giving small boluses as well. If somebody is on work, shift work, forgets to bolus, we eat 6 times a day, we don't take 6 boluses. So this meal detection technology can help you to take that extra boluses as well. Another thing is that lot of the times it will change the way you get insulin. So earlier if your carb ratio is 10 and if you are eating 60 grams, you take 6 units. But here the algorithm may not give you 6 units. It may reduce it because if it thinks that it will cause sugar less than 70 or 80 depending on whether you are eating or not eating. Now there is one more misnomer here, we call it active insulin time. Unfortunately, it is not an active insulin time. We are telling the pump that how long the insulin will remain active. So now the engineers have come up with new term, they call it algorithm intervention time. Because in 7-ATG, if you want to get the best outcomes, the AIT should be 2 hours. Now all of us know that pharmacokinetics of insulin hasn't changed. So how can you reduce it from 6 hours to 2 hours? We are doing this because we have safe correction bolus and safe meal bolus, and we are doing this so that you can give more insulin. That's the only thing that we are doing it here. Now my last part of the talk is looking at, does this algorithm work in India? Because we are different, our food is different, and our food contains so many carbs. So does this work here? Okay, let's look at the data. So I went to Singapore and I was giving a small talk to the Singapore General Hospital doctors, and they said me, okay, if you have the unlimited resources and unlimited money, and if my kid develops type 1 diabetes, where would I go? And I was thinking, okay, what should I answer? And then I thought, okay, the Nordic countries have the highest prevalence of type 1 diabetes, so I thought, okay, I may go to Steno. And Steno has the biggest hospital in Denmark, Copenhagen and all. And recently this data was published from Steno. And what they look at the timing range of the people with type 1 diabetes who are using different technologies. So there is an evolution of technology. There are people who are using MDI plus CGM. Now in India, MDI plus BG monitoring is the standard. I am assuming, again it will vary from center to center. But there the standard of care is MDI plus CGM. And you see timing range is 54. And if they are using automated insulin delivery, it is 72.5%. So if I go to Steno, I am guaranteed, and if I am getting AID, I will get 72.5%. Now another thing is that we are fixated with the green zone, but let's look at the time below range as well. So time below range with AID is lower than with your MDI plus CGM. That is also important thing, because if somebody gets hypo, he will remember it. That's the biggest. So now, can we beat Steno in India? That's the question. So when this system was launched in India, we wanted to analyze this data. And so first 6 months of data, we look at 219, and this was real world data. So there was no like a Medtronic sponsored study where we were taking extra care, we were looking at them, we were titrating it. Real world data 219, and we hit 75.4. So now if somebody asks me, do I want to go to the Nordic country? No, I'll say I will stay here. We have a AID. And we have the best doctors earlier also and now also. Unfortunately, they didn't have right tools. So now we got right tools, so why should I go there, Now let's look at another thing, is that this was the, again don't take photos of this, this was just on submitted to ATT Asia, and This was from data from 3 centers we look at in India, and timing range was 75.9. So it is not like one single fluke. We continue to get this kind of outcomes, and if you look at time in tight range, which is a newer metric where we are looking at 70 to 140. I think in one of the talks the question was asked, if somebody is on combination therapy and HbA1c is 5.8, what will you do? Will you taper down? I don't know. I think that it should be less than 5.6, but that's my personal opinion. But what I'm saying is that time in tight range is also 50.6. That's its key. Now look at across the ages. Does it work? So this was the data which was presented at ISPAT, and they look at Europe versus India, and when the data was analyzed, we get almost similar. Again, there was no comparison or p-value or anything. This was just like looking at 2 data where we look at, and the number of children was 160, and we almost got as close to European children. And you look at time below range, which was lower than what we were getting in the Europe. So that's amazing. Now look at older population, type 2 diabetes and all. Again, it's off label, it is not indicated in type 2 diabetes, but just we wanted to show you data. It is published. So when you look at in type 2 as well, it gives a beautiful outcome. So even in the old age or young age, it works fantastically well. Now across meal management, how many of your patients can count or gamble carbs? Perfectly, very few. So if I am giving this system to him, will he be able to manage well or not? So that is where we always say, you don't need to be accurate, just estimate the carbs and you will do well. Now you will ask me, what is the evidence? So this was the study which was done in Qatar and in the pediatric endo, and they look at flex versus fix. So fix means based on your carb consumption per day, they ask the patient, okay, if you are eating small meal, enter this much. If you are eating intermediate meal, enter this much. If you are eating large meal, enter this much. In India, we say 30, 60, 90. You know, small meal 30, medium meal 60 and 90. Now, when they look at this, the timing range was better with one who was trying to change the carb content every time. But even if you are entering the fixed carb, you still get more than 70%, which is good because you are reducing the burden. So in diabetes, one of the aspects is, can we reduce the burden of diabetes? And that's what we can achieve. So I always say, when you are using AID, the most important part is sometimes they forget they have diabetes. And I think that is the mission that we should look for, is that we should make them believe or make them feel that they should have diabetes so that they can do all these wonderful asks. Now one thing was that, what is the next? So these all we know over the progress. So with hybrid closed loop, which was the earlier version, which is available in the US and Europe, not available in India, we can hit 72%. But if you are using with optimal settings, that is 100 mg per deciliter basal target and 2 hours of activity, you can hit 80% of the time in range with this technology. And I think that is fantastic if you are looking at the outcomes. So I always say, CGM is not enough, question mark. If with CGM you are getting these outcomes, great. But on this note, I would like to thank you and thank you, Chair.
Thank you, Dr. Mukhekar, for an excellent lecture.